Hi, everybody. I am so excited to have the Kathy Mills Chang here with us today. I'm even more excited to see her beautiful face because I was supposed to be able to see her live and in person last week.
Yes.
Until somebody decided to spread their germs with me, exposed me to the COVID, and I was banned and had to stay home, and I was grounded on house arrest. I'm happy to report that I will be off this house arrest, and I have no COVID symptoms still in T-minus 48 hours.
Yay.
But I miss her so much. And in like 3 weeks, I'll actually get to see her live and in person. Y'all are going to feel a disturbance in the force when I give her a hug because I haven't seen her in over 6 months, which is ridiculous. Absolutely.
And we'll have a green sticky so I can hug.
I will. And in fact, I thought about making my own big green sticky so everybody knew.
Right here.
Right here. So we are so excited to have her talk to us about how to minimize Medicare risk. And I can't think of anybody better who has more experience in dealing with all things of any kind of payer plus Medicare. I mean, there's nothing, in my opinion, that Kathy doesn't know about dealing with all of this stuff that is basically giving you guys all a migraine. And who better to explain to you, break it down to the lowest common denominator, make it really easy to understand. Because let's be honest, I think that they set out all these payers, Medicare included, to make it as complicated as possible for us to understand what they mean. So everybody, the Kathy Mills Chang.
You are my favorite. Thank you so much. I haven't been with you on these webinars in a while. It's a pleasure. I'm so happy to be here. I have kind of two screens, so I'll look back and forth, but we're going to dig through the idea of Medicare, and I know it's everyone's favorite thing. If you have a question, don't hesitate to pop that in. We'll be able to answer along the way or at the end. And I'm happy to stick around and answer as many questions as there are. We're going to strap on our seatbelt and go pretty fast because there's a lot to cover. This is not going to be a basic Medicare class. You've had enough of those already. This is kind of all the nuances and the crazy things that are happening as we go. As I always have to say, we don't set practice standards. It's important for you to know that I own KMC University. I don't want to in any way not disclose that so that I'm not here for any other pretenses, but to help you today. Under all circumstances, these are my views and opinions. When something is the regulation or the law or the rule, we certainly will tell you that. But as with most things in Medicare, there are some gray areas, and I'll let you know when something is one of those. It's not new. There's nothing here I'm going to tell you that's too new, except for the changes to the ABN form that are coming up. But everything should be available to you in the public domain. I'm just going to give you some of my kind of 2 cents about it, if you will. So this is, again, a little bit more intermediate to advanced, not really the basics of Medicare. Some of these things you may feel are basic, but every time I speak, and as Christy mentioned last weekend, I was able to be at a live event, first one since Parker Vegas in February, and I'm always surprised at what I think is basic that some people will have no idea about. And that happens with doctors that are coming out into the profession, and also CAs that are new to the practice or new to billing, for example. So we will continue on with these things. So let's first talk about billing compliance with Medicare. Step one is you have to know the difference about how Medicare functions with chiropractic. So we have 3 codes, only 3 spinal codes that are always a covered service under Medicare. They are always a covered service because they are our only covered service, 98940, 41, and 42. Now, there are circumstances under which those covered services may not be medically necessary. That's when maintenance care exists, or we don't meet the definition of medical necessity, or perhaps they've had more than one visit in a day. Everything else we do is going to be deemed statutorily excluded. Statutorily excluded from Medicare because they're simply not covered when ordered or delivered by a doctor of chiropractic. The second thing you have to know is for Part B Medicare, you have to enroll if you want to touch them. And that's for a covered or a statutorily excluded service. So must be enrolled with your Medicare administrative contractor, have a valid number, and in order to see them, even if you're performing a service that is not covered by Medicare. You must be equipped to bill That is the rule. Surprised that we still have doctors that try to work around that rule kind of at any turn. Part B coverage, of course, is this, as you can see here. Most of the senior population has Part B, although more and more are moving to Part C, as we'll talk about in a moment. And Part B, for all intent and purposes, is actually optional. So keep in mind that there are no obligations for a Medicare senior to accept Medicare. For them to say, I want to buy Part B insurance, they don't have to. Part A is kind of a gift, but Part B is optional, and they do pay a premium for that. I wanted to show you kind of this fun new graph that we have, or flow chart, because I think, all the times I have to explain it, we try to figure out the best visual that we could possibly do in helping you to understand it as well. So you notice at the top it says, accept and treat Medicare Part B patients. So you don't have to, as you can see down the no side. It means you're not enrolled and you turn them away. Very simple. But it is not about billing. It's about accepting and treating them. So if you say yes to this, notice that you have to be properly enrolled. But in addition to that, look at all the rules that apply to you. We have a little color code key down at the bottom, but you can see that you have to charge the right fee. There has to be, if it's active treatment adjustments, they must be billed. There's mandatory rules about that. They have very payer-specific documentation requirements to follow. There are medical necessity guidelines to follow for compliance. Coding is going to be based on your documentation, and those modifiers have to be used. And then you notice, now we have a choice of being par or non-par. And under these circumstances, you can very clearly see that all of those other rules apply whichever you are. So some doctors take on the attitude that I'll just be non-par and nothing applies. Clearly, that is not the case. Now, the advantage of being non-participating is that you do have some choices. You can accept assignment on a case-by-case basis. Maybe Millie Medicare can't afford to pay for their adjustment at the time of service 3 times a week for the next 4 weeks. And you're willing to accept assignment and accept a little less for those adjustments. On the participating side, you don't have that choice. You're simply billing and waiting at all times. In addition to that, there is a regulated fee that limits what you're able to charge, and that is called the limiting fee. If you're on the non-par side, you go ahead and bill your actual fee on the par side, and they'll remove that down to the allowed fee for participating providers. So if the answer is no, then it's no. But the moment that it's yes, you accept them and you treat them, these rules apply. Part C coverage is becoming more and more popular. Patients are opting over into Part C, which is a little more of a managed care world. The patients who have Part C coverage are generally being covered through some type of a generalized health insurance, maybe a PPO, HMO of some kind. And they do that because, especially coming up here to the end of the year, you're going to see a lot of people make changes. Open enrollment is right around the corner. So open enrollment works for chiropractors to then choose to go from par to non-par or non-par to par. This is the time of year you can do that. And for patients, they can choose different insurance at the end of the year. That's why we always verify at the beginning of the year. That's why we always do these little nuances to make sure that you always know what that patient has. Unfortunately, sometimes patients don't even know what they have, which is sad. But they've changed because somebody in Walmart drug them over to the booth and told them about this, and it sounded good because they didn't have to buy a secondary insurance anymore. So it will be a private carrier that deals with that, a private kind of fee-for-service plan. So unlike Medicare Part B, you have a choice about Part C. You do not have to participate as a chiropractor in Part C. You may elect to be out of network with their plans, and when they come to the office, they're treated as any other cash patient would be treated. And I'll go into some detail on that for you in just a moment. You have a choice. You don't have to. I want to tell you that sometimes your choice may be taken away because, let's take Anthem Blue Cross of whatever state you're in. To be in their commercial plans, they may require that you're in their Part C plan, and you don't have a choice. If that's the case, you're stuck. But if you have a choice, you don't have to enroll in these plans. And if you're not sure, you should definitely find out. So look how much more complicated our flow chart is for Part C, because it is complicated. Let's start at the top. Do we accept and treat Part C patients? Again, if the answer is no, very simple, not enrolled in anything, we send them elsewhere. And goodness, I hope you don't do that. There's no reason to do that. I did an interview yesterday with someone who asked me about why doctors are so afraid of Medicare, and I don't have an answer. I think you've been misinformed by people too long or heard rumors that are not true. Medicare is one of the most straightforward, I think, simple things that frankly pays pretty well. And with the 10,000 people a day aging into Medicare, it's silly to worry about it, and rather just do it properly in your practice and enjoy the benefits, and more importantly, help those people who need it so desperately. So let's forget the no, because I don't think you should do that. You have choices on this one. Let's say I am going to accept and treat them here over the yes, but I want to remain non-participating. Notice that I'm not required to bill them. I am not required to bill the insurance if I'm out of network. I may elect to do so, but let's take the little arrow over down into our green square. As with any other type of patient, if I elect to treat them and to not bill their insurance, these are the rules. I can charge my actual fee, or I can implement a legal and compliant discount like ChiroHealthUSA. I can provide a receipt or super bill for the payment. I never want to use a 1,500 billing form ever, because all the rules apply to me if I do it. But a simple super bill with information about the coding, the CPT and the ICD code are what are most important, and show it paid in full. Patient deals with their payer. Follow your state board and liability payers, kind of your malpractice insurance's minimum guidelines. Make sure that you cover documentation, and that's it. But the moment that you wish to go ahead and elect to bill, you could become a deemed provider. For that patient, you will then become in network and expected to accept the fee that you have now kind of alluded to. The insurance considers that you're a participating provider. There's a whole myriad of rules. I could do an hour on this alone that talks about if you could have known or had a chance to know that they were Part C and that this would happen because you billed them. Unfortunately, you're stuck with it. It's the reason that we impress upon you so much to verify every Medicare patient. So you know where they are, you know what their coverage is. And if you notice below here, all of that's just the same as it was with Part B. Now, assuming on the right side we are participating with their plan, I may be limited to that contracted fee that I've agreed to, but in many circumstances, they may also cover other services. So let's say that the patient has a $30 copay, and the allowed fee under that plan for the adjustment is $29.10. Well, we certainly are not going to collect the $30. We collect $29.10. And isn't that patient just a cash paying patient anyway? So it's another one of those things we want to evaluate at the end of every year. What plans are we in? What are those coverages? Where is our collected average for that particular plan? And the details of the business essentials of your practice. Because then, as you can see, continuing on down, all the same rules apply. So most important takeaway for Part C, don't have to enroll. Those patients may be treated as cash. And of course, you'd want them to be under your ChiroHealthUSA fee schedule. So the life cycle of a patient across time in your practice is going to be almost like that book of their life with chapters. And the chapters are the active episodes of care. They move in and out of active treatment, certainly very regularly. That would be something not unusual at all. And that kind of, the event I spoke at last weekend, I had the doctors tell me who they thought had a patient in their practice the longest. And there was a doctor there with patients who have been there for 32 years, the entire time that he's been open. Can you imagine that health record? Well, I would never want to have to dig through that whole thing. I want to look at the chapters of active treatment with periods of maintenance treatment in between. So from a documentation point of view, Medicare is going to want to see all of these things. And I think one of the very, very most important things that we can share with people and with our doctors is that at all times, we need to know whether the patient is in an active episode of care or not. So is there a treatment plan that we're following, and it is very specific, so many visits have been recommended, or is the patient on return as needed or maintenance care? If they are, we treat that a bit differently because they're not in this active episode of care that you see with this green circle. Those patients are being managed in a particular way, case managed by the doctor. So if we're going to be billing for those things, case management is critical, extraordinarily critical. Because if you notice this, patients kind of move in and out of active care all the time. That's the management. So from active to wellness, back into active, maybe they go off and stay away for a while. All of that could be very normal, but during the time they're active, it is very carefully managed by the doctor. And of course, CAs, it's our job to help them and keep them on track. I tell a story all the time about an on-site visit I was on where walked into a room with the doctor and the person hadn't been in 8 months and they were sitting there just ready for an adjustment. Of course, that is not how we would manage that. CA at the front missed the boat on when the patient called for the appointment, asking the right questions, missed the boat again when they came in for the appointment, asking the right questions, and in rooming the patient, the scribe missed all of that. So now we would have put all that on our doctor to suddenly have to do a full workup on someone who hadn't been in the office in 8 months. And had we before, and we certainly did it right then, train those CAs in how every phone call, we need to know where they are. Pull them up in the computer. Am I in an active episode? How do you know that? Where do you find that in the system, in whatever system you use? It is one of the most critical pieces of training for CAs and frankly for doctors that we do. So think about kind of these puzzle pieces. So for an evaluation and management service, and of course, we're all familiar that there will be brand new E&M services and rules that come out January 1st, so be sure you're prepared. KMC University clients already have been trained. We expect some more clarity November, December. We're probably going to do another webinar around then, but the rules have changed for the first time since 1997. This piece is one of those things that has this piece hasn't changed, but what will happen is in the way we select our code off of these pieces, that has definitely changed. So think about inputs first. We take in the patient's history, we take in the patient's examination findings, kind of goes into that doctor thinking head. And from there, the doctor produces some outputs. The assessment, different from the diagnosis, you also need that. And then, of course, the plan. And when all those puzzle pieces fit together, we have generally established medical necessity very well. Medicare is going to expect that these guidelines are followed for documentation. Again, we could do a whole hour on this, so I won't take a lot of time. But what's the most critical takeaway is that for every new episode of care, whether it's for just a couple of visits planned, 1 visit planned, 30 visits planned, the components of what it says here for an initial visit need to be in the record. So what's the history of whatever's going on now? What are the exam findings to quantify that history? And you can see that whole thing kind of comes together again as a new foundational visit for that next episode of care. One of the most important definitions you can know is the definition of medical necessity per Medicare. We should be able to come to your house and shake you awake at 2 in the morning and you can go bleh and spit it out because this is critically important. And essentially, it is where many other payers choose to pull their definitions from. So knowing this one is really important. And the key components are underlined here. So you have to have a significant health problem in the form of a neuromusculoskeletal condition. So that is your patient's secondary diagnosis that goes along with the subluxation. So what is the subluxation causing? That really is why you have to have a pair of diagnoses for every region of the spine that's being treated. And the manipulative services rendered must have a direct therapeutic relationship to the patient's condition. So if I'm coming in with neck pain and headaches and you're trying to bill for adjusting my pelvis, not going to work in Medicare. There are many ways that you can still treat that patient as a full spine adjuster, but not as billable services. And then last, but maybe most importantly, we have to make sure that there's a reasonable expectation of improvement or restoration of function. The patient has to be able to get better. The moment we get to where the patient is staying in one plane and we're treating them to keep them from getting worse, that is by definition maintenance care. Full spine adjusters have a tough time. The linchpin of this, and what is important to understand, is that treating the patient is one thing. What is billable is another. There needs to be subjective and objective for every region you plan to treat and bill for. There need to be diagnoses and complaints in those regions. And so often the doctor is just so used to adjusting full spine that they create that when there is no complaint, and they haven't gone the extra mile in the history to kind of dig that out. Or we get to the exam and we're now examining another area of the spine, and the patient goes, oh yeah, that does kind of bother me. And we don't go back and admit that into the history as well, which is very, very important. And those are pieces that have to be done. Noridian, who's a large Medicare administrative contractor in the West, has decided, or this is from last year, they're doing a targeted review of 98941, because it used to be everybody was a bad guy if they did 98942. Now 98941 is seemingly abused at the same level, because when documentation is reviewed, there is not enough detail to show why there are at least 3 regions being treated. And this is spreading its wings over into other types of payers as well. Here's an example from a company called ChiroCare or Fulcrum, and you can see that they very clearly state a complaint involving at least one spinal region, an examination in that region, and the diagnosis. Now here, for 98941, at least 3 regions of a complaint. This is some of the first language that we've found that says there has to be a complaint. And not unlike them, Optum has put out their CMT policy to say the same thing. Now they go on to show, this is of course not a Medicare situation, but it's important to know about it as well. But you can see here, validated diagnoses for 3 or 4 spinal regions, validated diagnoses for 2 spinal regions, plus 1 or 2 adjacent spinal regions with documented soft tissue and segmental findings. This is the reason why we have such a hard time with billing 97140, because they have rules that say contiguous versus non-contiguous areas, what can be billed, what is billable, what is reimbursable. And unfortunately, they've had to go so far as to be this detailed to help us understand. And honestly, if anyone is east of the Mississippi River and does VA, these are the same rules that apply to you there, as you can see, because Optum is the payer. West of the Mississippi, it's WPS. But this is one of the most important pieces that you can see, is that there has to be complaints in order for a region to be billable. But does that mean you can't treat it? Because you need to stabilize it in order to address the more primary complaint. Yes. We certainly know there are techniques such as Thompson and activator where a doctor may have to address a certain compensatory area in order to stabilize a primary subluxation. So the question becomes, is the subluxation you found creating a secondary neuromusculoskeletal condition, or just a subluxation that needs to be addressed and corrected because there's no lack of function that goes along with it? No harm, no foul, but we document that in a particular way, and we only bill for those active treatment areas. The complaint should drive the examination. That will then drive and report the diagnosis and assessment, which then yields the treatment plan. No complaint, no covered adjustment. That's just really as simple as that. Could you help the patient perhaps to remember or dig into that a little bit? Of course you can, because I find especially gentlemen, play it down so much. No, I'm okay. My low back, it hurts once in a while. It's no big deal. They don't understand. So it becomes quite a patient education experience that we have to get into. So this is an example. Unfortunately, it covered this up, but the animation just removed, but I'll tell you a little bit about what happened here. So the patient is a truck driver, driving from Miami to Philadelphia, pretty much pain-free, doing very well for 3 years. Past history, there's no conditions that we need to worry about. There's some anterior head carriage, there's postural issues, and certainly a tremendous amount of low back pain. They do find the forward head carriage and the rounded shoulders, but what we find here is that the doctor wants to treat full spine. So in this instance, because it is a lumbar complaint, it would be the lumbar area. We don't have permission to adjust that neck and bill for it. Certainly it could be billed and listed as a compensatory area. No reason not to. And the $64,000 question for most people is, then why can't I charge the patient? Just don't. It's not appropriate. In Medicare, coding is the same as it is everywhere else. In fact, codes were created for Medicare, of course. So these are all things that you should very well already know as far as regions are concerned. And when we work with a member to assist them with really the business side of the practice and understanding their compliance, coding audits and things of that nature, I like the idea of making sure that your software is set up in such a way that active treatment non-Medicare adjustments are listed as just 9894041 and 42. Active treatment Medicare are in your system with that AT modifier. Same 3 codes. Maintenance care, S8990 if I'm outside of Medicare, and the 3 codes with GA if I'm inside of Medicare. Now at a glance, as a compliance officer, I can come in, I can pull that data, I can see your ratios, I can look for hotspots, I can find red flags. But unfortunately, some of our fee systems and fee schedules in the computer are so jacked up that we don't even have a place to start. This is best practice. Obviously, primary diagnosis has to be subluxation in Medicare. Certain states don't require you to list both on the bill, but they do need to be in the medical record. Beware of a situation like this where we have a group 1 code showing the head as a subluxation when clearly that's an extraspinal region and would not be paid. Our Medicare administrative contractors have changed, especially as of October 1st, with the new ICD-10 codes that came in. They've changed the rules and sort of removed all of the diagnosis coding from the LCDs and moved them into an article. In many cases, the article doesn't list any diagnosis codes because the premise is that a provider can use any code that is applicable. Example was given to me that if a patient has a complication of, say, multiple sclerosis. Prior to this, we couldn't even show that as a diagnosis, complicating the fact that they're sitting in a wheelchair and aggravating their spine. So it's good in that way. What isn't good in that way is that our doctors are still defaulting to minimal, non-descriptive diagnosis codes like cervicalgia and lumbalgia, and trying to treat the patient longer than 4 or 5 visits. So I like that some of the payers still give you the full list, and if nothing else, at least it's a guide. This many visits for this many visits for that. So I do encourage you to try to find that if you can. KMC University clients, we have all of that in the library that you can refer to. Even if this payer is not your payer, again, can simply use it as a guide to get a general idea. Self-auditing is a part of compliance. Installing a compliance program in your practice is a required element. From Medicare, it was part of PPACA, and it came out of the sentencing guidelines that you had to have a compliance program in place in order to participate with Medicare or see Medicare patients. Part of that is that they expect you to do some self-auditing and to routinely not only do a baseline audit, which is a part of that, even though some don't do it, and you're supposed to. Don't install a compliance program, please, without doing a baseline audit to know exactly where you are first. And under those circumstances, you will not know where you're going if you don't know where you started. But audit along the way. Make sure that you are randomly pulling charts and comparing to what's being billed. ICD-10 audit is a part of that to see if you're kind of falling into habits of just billing the same diagnosis codes over and over again. Those are all concerns that we want to avoid. So the AT modifier means active treatment. When the AT modifier is on a bill, it means something. It means several somethings. It means I will raise my arm to the square and promise that this is medically necessary and I expect you to pay Medicare. And if you don't, I'm going to appeal it because that's how certain I am that this should have been paid and is medically necessary. We know that our profession is not using that as I just suggested. Sometimes it's automatic. Sometimes it's not really well understood. There are screens, as I showed you on the last slide, where insurance, some have said this many visits are probably appropriate for these diagnoses and this many for these. And we can get a general idea. If we feel the care is still active beyond that point, then at that point, it is when we use an ABN and we begin to say, you're probably exceeding the screen. Doesn't mean we can't bill it and get a denial and then go after it in an appeal. But those are the reasons why we have the AT modifier. Now, the opposite of active is maintenance. And in Medicare, they've given us this diagnosis or this definition. And in this case, it actually has two parts. The first part is that it is a treatment plan that seeks to prevent disease, promote health, prolong and enhance the quality of life. In chiropractic care, that's wellness. Wellness care is maintenance care. On the second part of the definition, this is where I see doctors going wrong the most. And that is because it's kind of more directed at supportive care. And that is therapy performed to maintain or prevent deterioration of a chronic condition. So if I've gotten her to here and I have to keep treating her every 3 weeks or she'll drop back down, that's the definition of supportive care, which is maintenance, which is patient responsibility. No AT modifier. So understanding that, I think, is one of the most critical things that can happen for you as you go individually. So again, I'm sorry, this is kind of an animated slide. So I just want you to know that these are the modifiers that would apply to you for anything to do with your 3 spinal CMT codes, AT, GA, and GZ. For everything else, GY, GX, and GP. So for billing and for fee schedule setup, this is the way you want to set those things up and to have them available to bill appropriately. We know there are so many issues. I won't go into detail since they're kind of not able to come one at a time. But the AT modifier is something we see so many mistakes made on. And again, it goes back to kind of the chicken and the egg. What came first? Well, what came first is not understanding when to use it, not understanding the definition of maintenance versus active. And by doing so, you can correct all of those problems kind of at one time. We are very fond of this tool, the Medicare Decision-Making Matrix. It is an opportunity to be able to determine, is that patient in an active episode of care or not? And when they are, what are the questions you ask yourself to figure out if it's still active? And if it's not, is it a new condition or not? If it's not, after checking the patient, would it be deemed maintenance? After that, does the patient want it and understand they need to pay for it? So we're going to go into some detail on the ABN here in a moment so that I can share with you the rules that will change for you on January 1st. We were supposed to have that happen at the end of August, but they've delayed it until January 1st. So in simple terms, the initial visit of an episode of care is where the box 14 starts. So the first day of treatment is what goes in box 14 on the billing form. It is the condition date. From there, the patient improves, gets to a place where the doctor discharges the patient from that episode of active treatment. From that point, if the patient returns, we do not assume maintenance at the end of that visit. Maybe they're told to come back in 3 or 4 weeks. It is then that we go through that matrix and ask ourselves the question, are they here for something new? Is it still going to be maintenance? And the first visit of that period of maintenance care, if it is where the ABN form is signed. An ABN form is only to be used when an otherwise covered service, those 3 spinal CMT codes, will not be covered today due to maintenance care. So we have the ABN signed, assume the patient chooses option 1 or 2. There is now the GA modifier on the end of the adjustment, even if you're not submitting it because they told you use option 2. Even if that's the case, no problem. But we still want that in our computer system to know how much maintenance versus active are we doing. That's a compliance consideration as we're continuously looking to improve. So patient might go on for maintenance care for a while, and then box 14 starts again the next condition. Maybe they go 3 months on maintenance or 3 months being away, come back, have something new, and we start again. The ABN form signed at the end of the previous care now is end dated, no longer applicable, and we have a new active episode called a triggering event. Now there's no ABN in play until we get to the end of that one. Every ABN is good for up to 1 year from the date it's signed unless there's a new triggering event. So in this instance, when that new active care episode starts, the old ABN is no good. We have active treatment, we get a new one, that is now good for 1 year. So there is a new ABN necessary as of January 1st. You will find this date at the bottom to know that you're using the right form. There have been a number of rules that have changed. I do suggest you go ahead and update it now. Your other one is expired. There's no reason not to. It is required January 1st, but go ahead and get yourself up to date now. We should clarify mandatory versus voluntary ABN. As I mentioned, mandatory ABN you must do. When an adjustment of the spine will be deemed maintenance today, ABN has to be in play. Voluntary is for everything else. If you want to notify the patient that exams, x-rays, therapies are not covered, that would be voluntary. It is not required by Medicare. And for the love of God, please don't use their ABN form for this. Please. That will just add insult to injury and more things that you have to jump through hoops of. Just don't do it. I'll show you a better way. So you can see here, these instructions should only be used when the ABN is used to transfer liability and it is for covered services, not involuntary instances. And this is the horse's mouth. This is their rules I'm reading you, not mine. They're all referenced. I'm happy to provide that reference for anyone that may be confused about it. These are the new guidelines that just came out. And it kind of goes into a little bit more detail with that fourth bullet point there that we didn't have before, because it's for an item of service is not reasonable or necessary, because it's not that it's not covered. Of course, an adjustment's covered of the spine. That's all we've got. But more than the number of service they would allow in a specific period for the diagnosis. If I've got cervicalgia, you're going to get 6, 8, 10 visits maybe, and then you're done. So that's when this issue come into play. You can also see here that they do certainly recommend that you're using an HETS system for verification, going into your portals, going into your clearinghouse, and especially those of you in states where you have patients moving back and forth throughout the year, it gives you the opportunity to see what's been going on with them, because it's a central receptacle, not just a Medicare carrier. If I go from Colorado to Florida, those are two different payers, so two different systems. HETS will kind of aggregate them all, though. And this is a reiteration that ABN is good for up to 1 year, assuming there has not been a new triggering event. This is where it's very clear, just so that you understand, the ABN is not necessary. Before you furnish an item or service, they never cover. And as I said before, that's all the statutorily excluded services. This is right out of their book. You do not need an ABN for those services. You need them when it's an otherwise covered service, such as that CMT code. Very important that you understand the rules of ABN, filling in all the blanks, seeing what it should look like. And I'm going to kind of show you what is important for you to know about your mandatory ABN. So there should be a notifier right at the top. That's where you personalize it with your information. Every place that you see circled is a letter D, and that letter D, for all intent and purposes, is going to be your place to say this is for maintenance care. Where you see the covered services, that's your code. Those are the 3 spinal codes. That's the only thing that needs to be there. And in that center box, that's your maintenance care. And again, 99% of the time, it's going to be that reason. 1% of the time it might be for a second visit in the same day, but that's when you're going to go ahead and just make a special ABN for that circumstance. You are allowed to charge either the limiting fee if you are non-par, your actual fee with a properly executed ABN, or if you're a ChiroHealthUSA member and you've established a maintenance fee within your fee schedule, you may, if the patient is a member, extend to them that maintenance fee, but you have to know kind of who's who and what's what. There are 3 options. Option 1 means I want it. I still want you to send the bill because I need it to be potentially adjudicated. I may need to appeal this. If you do not submit the bill, it cannot be appealed. So even for doctors that feel like you're approaching the end of a screen, it's important to know I've got to go ahead and send it in if they check option 1. Then I can react to that EOB that comes back showing patient responsibility. Option 2 means I don't even want it billed. I get it. I understand. Don't bother. And option 3, if they would sign it, means I'm done. I don't want it. I'm not having maintenance care. I'm out of here. I know sometimes they won't sign it, but try to get them to sign it if you can. Sort of a against medical advice statement. So it's not a bad thing to do. Assuming we have an ABN and we have to bill, we now replace the AT modifier with the GA modifier, meaning I got an ABN. And of course, it doesn't mean that, but I like to think that it does. If you are a I'm sorry, Chrissy? No, I think I heard voices. If you are a non-participating provider, it's critical to understand that you need to have the non-participating ABN essentially show that on option 1, this line item right here is crossed through. And it needs to be crossed through on your master because, of course, if it's non-assigned, they aren't going to have to refund the patient because the patient would receive any monies eventually back at their home.
Did I say alcohol beverage? I don't think I meant that. I meant just get y'all a beverage. Y'all
What's
forgive
that?
me.
Did you need me? Christy, did you need me? No? Okay. Okay. And Christy, I'm not sure if you know you've unmuted there. Just wanted you to know. So ABN errors are no joke. We don't want to have these type of errors on the ABN form no matter what we do. Super critical. Now, for the voluntary use, remember that it's a choice. We don't have to do this, but of course it's best practices if we have the ability to notify a patient that they're going to be financially responsible for certain things. So in this example, it also shows that the Medicare black and white ABN form is really only meant to be used for Part B. It is not meant to be used for Part C. If you participate in one of those plans, talk to them about what they would like you to do. So just don't use this for voluntary circumstances, even with your evaluation and management services, your x-rays and all, just don't do it. It is not a good idea because the rules say you cannot have them sign it and you can't have them choose an option. I would much rather you do something like this, which is really a special notice. Put it on your letterhead. Hey, Medicare patients, this is how it works. We're a member of ChiroHealthUSA and we have discounted fees for these kinds of things, but they are never covered by Medicare when ordered or delivered by a chiropractor. And then you're not subject to any of the rules. They can sign it, they give them a copy, and it's a wonderful, wonderful thing. Hopefully you love Bill Esteb's brochure. Patientmedia.com is where you can find this. I assisted him with some of the language in there, but it was all Bill-isms, as you can imagine. Wonderful tool to hand to a patient at visit 1. Really wonderful tool to help them understand and start that process off on the right foot. So what I'm going to share with you now really is very specific to something that has been around but has all new rules that are especially applying now and through January 1st with the new ABN. So there's such a thing called a qualified Medicare beneficiary. These are people who are dually insured. So they have dually eligible, I should say. So they have Medicare and Medicaid in most circumstances. Because in these circumstances, they may be receiving assistance with their Part B premium or with their deductible or with their coinsurance, excuse me. So under those circumstances, we may not bill those patients. Here's an example of what their card might look like for Medicaid. It has QMB down in the corner. We are not allowed to bill a QMB for cost sharing on covered services. Now, in the general scheme of things, a QMB certainly could pay for the statutorily excluded services, and I'll tell you more about that in just a moment. So dually eligible are generally those two plans. They are generally in a situation of financial need. There are millions of people that qualify on this and probably even more in our current circumstances. And the coverage will vary from a state to state basis, the same way that Medicaid coverage changes. So this is really funky. And it is something that is relatively new, so I wanted to show you the reference so that you wouldn't think I'd lost my mind. So the Social Security Act indicates that Medicaid agencies must reimburse providers for QMB cost-sharing amounts without regard to whether the costs incurred were for items or services for which medical assistance is otherwise available under the plan. So what that's saying is, even if you're in a state where Medicaid does not cover chiropractic, they have to cover chiropractic for a dually insured QMB. Very simply stated. Medicare should cross that claim over to Medicaid, and they should process it. Now, they may require that you enroll in some fashion in order to do this, but it is the law. You can see here, Medicaid agencies' obligation to adjudicate and reimburse providers exists even when the service is not covered by Medicaid, irrespective of whether the provider type is recognized in the state plan or QMB coverage. QMB is eligible for coverage. They can require that a provider agreement is filled out, and regardless of the specific enrollment mechanism, they have to enable all Medicare enrolled individuals have to be able to submit a claim in some way to accommodate for those QMB patients. And what this is telling us now is, even for maintenance care on a QMB, you may not submit the claim or ask the patient to pay at the time of service for maintenance care. It has to go all the way through Medicare and Medicaid and be adjudicated before the patient can be asked to pay. So there are a whole lot of rules and regulations that go along with this. We certainly can move along. One of the advantages we have of being the size company we are, with the reach that we have and the experience that we have, is that we have some inside kind of help from Medicare. And so we have people at CMS and the different payers that we know we can get answers to when other answers are not given. So this is an example of something they published in an FAQ based on a question that we sent, because we sent the question in and our answer was, hey, that's a good question. We don't know. Let us go figure it out and we'll let you know. So this is exactly the question that I said earlier about collecting at the time of service for the excluded services. Can we do that? So if Medicare expressly excludes coverage, let's call it the E&M service or X-ray, and the beneficiary has QMB coverage without full Medicaid coverage, the provider could bill the beneficiary for the full cost of care. Now, guess what that means? You have to verify and you have to know what they have. You have to know whether that's okay. If the beneficiary has full Medicaid coverage, then it has to be that it goes through all the circumstances first and deny, or pay, whatever that is, before you can go back to the patient for receiving these payments. So this is new. This is within a month or so ago. So it may not be the way you practice now, but it is very important that you understand this is a serious compliance issue. Start watching for those QMB patients. Also, you can see here that on the ABN, you have to require that the patient sign option 1, and you can see that we have to cross all of these little pieces out because we have to submit to Medicare first, and they have to go through all the way to Medicaid. So let's wrap up by talking a little bit about charging and billing and the monies and what we can collect and what we can't collect and so on. So if you are a participating provider, Medicare has an allowed fee that they will have for you. We've all been hearing the horror stories that all the fees are going to go down in January. Call your representative and senator and talk about that. But we will find out what our allowed fee will be as a participating provider. If you're a non-participating provider, there's a limiting fee that's about 115% of that number. And that's what you're able to charge. Now, on your covered services, your excluded services, of course, you must bill your actual fee. If you're in one of those couple of states that allows for a small percentage discount at the time of service, that could be allowed. And of course, as you know, we certainly recommend that you just enroll in ChiroHealthUSA instead and set those fees where you want them and for what is best for your practice. You can kind of see the par allowable, non-par allowable, and limiting fee here. This is to help you understand these numbers are made up, but you can just kind of see that the par allowable is the maximum amount that you would receive if you're participating. If you are non-participating, you charge the limiting fee, that $31.60, collected at the time of service, submit the bill as required. Medicare, however, will only consider the one in purple, the $27.48, and pay that at 80%. So this difference between $27.48 and $31.60 in the example of 98940 is what the Medicare patient will never recoup. Call it a bit of a penalty for going to a non-participating provider. Always remember that you may not bill for family members. Medicare lays out all the rules of who that is. Most insurance companies have in their rules what you can and can't do for your family member, your spouse's family members, etc. The idea behind it is if you wouldn't have charged them if they have no insurance because you're married to them or something, then why would you charge just because they do? So pay special attention to that. Now, excluded services under Medicare are never covered. You do not have to submit them to Medicare unless the patient asks you to. Of course, if there's a secondary or they're a QMB, we now know we have to submit them because the patient wants that adjudication. Perhaps they have coverage that would pay for that. So make sure that you're billing your actual fees and you're following all the rules around those things. We have a doctor in Iowa a few years ago that was giving away electric muscle stim. This is a clear inducement. Turns out we have some insider information there and know that the CA actually reported the doctor after she got fired. And unfortunately, they did not have a proper compliance program in place with a proper code of conduct that would have implicated the CA if they went to whistleblow. So that's why we recommend that so heavily. And in this particular instance, the doctor maybe in his heart was not trying to induce, but unfortunately it looked like he was because, hey, come on in and get the muscle stim and I'm going to then adjust, I'm going to give you that free. So without a policy that said everybody gets muscle stim free, it's just a part of my adjustment, which could have been the correction there. Unfortunately, they violated the anti-kickback statute and the False Claims Act. And how easy would it have been for them to be a member of ChiroHealthUSA? And maybe they only want to charge $5 for an a la carte muscle stim. They let you do that. It's a no-brainer. Why would someone want to find themselves in hot water like this? And instead, when it's so easy to be a provider with ChiroHealthUSA and do it right. Do not give away any item or service to a Medicare patient, and I say any patient, that exceeds a value of $15 or $75 a year. You've got some flexibility around, hey, I'm having a coat drive and, you can bring in some coats and have a free adjustment. I know for a fact, having talked to an OIG investigator, those aren't the kinds of things they're worried about. They're worried about new patients and giving away free services to choose them, to influence them to choose this provider over another. So always charge your actual fee. Have a reasonable time of service discount. 5 to 15% is what the government says. North Carolinians can do a little bit more than that, but not for federal. Use a network-based legally discounted fee of choice, such as ChiroHealthUSA. And if you need a legal hardship or indigence fee, put that in, write policy about it, and do it right. You are allowed to help people who have problems with financial matters. So always make sure that you charge the right fee. Begin with that fee. And recognize that in your fee system, you have actual fees and you have discounted fees. Those are all there are, actual and discounted. From those discounted fees, we know that we then have, and there they are again, then we have imposed discounts that come off of your discounts. Those can be regulated or contracted. Regulated fees are things like VA and the Medicare adjustments and maybe PIP or no-fault fees or workers' comp fees. Kind of you take the patient, you take the fee. And you have elective discounts, which are those that could be 5 to 15%, ChiroHealthUSA discount, hardship, professional courtesy. Maybe a doctor doesn't charge their team members for adjustments. That's a professional courtesy. And if we do our fee system correctly, we have our actual fee. We have all of our contracted fees, such as Blue Cross and Aetna, including CHUSA in this safe harbor. We are allowed to have regulated fees for Medicare patients for the excluded services and still have a hardship fee schedule. Nothing stops us from doing that. And this is why we love this program so much, because it takes the difficult piece of having, a fee for whoever and pulling it into one fee system that is appropriate, compliant, and driven by policy. So, Christy, we'd certainly like the opportunity to remind your users and listeners here that there were a whole set of new ICD-10 codes that came in October 1st. ABN rules are changing January 1st. QMB is happening. E&M coding rules are changing for the first time since 1997. As we always do for your listeners, our discovery consultation, normally at $79, is offered at only $49 for those that may wish to get on the phone with a certified specialist, go through some questions, address an issue, and certainly we would be more than happy if there is something else you need to even apply that to the cost of whatever that would be. So I hope that you'll jot down this email or kmcuniversity.com/DC for discovery consult, or actually just give us a call. We'd be delighted to help you. And if there have been any questions that have come in, I'd be happy to answer them now.
Okay, so I have one that says, if you're not in network with Medicare Advantage, but in network with Medicare, what do you do in that scenario? And I'm sure it came up earlier when you were talking about Medicare Advantage.
Yeah, I'm wondering if that provider might have come in late. So there was a very interesting slide that kind of showed a flow chart of what you can or can't do. And if you are out of network with a Medicare Part C plan, you have to decide whether you want to see the patient as a cash paying patient or whether you want to bill and accept what the amount would be that they would pay any deemed provider. We'd be more than happy to go back through that for you. And Christy, I don't know if you're providing them the notes, but they could go back to that image in the note.
Okay. If you will all look down, you should see above the chat box that says handouts, so that you can see that. There's a whole bunch of thank yous, great infos, really enjoyed it, which is not at all shocking because she's amazing. And there are some people who, she is larger than life and even more fabulous when you get to spend more time with her in person at a live event. She just went through a lot in a very short amount of time. But if you get to do one of her 2-3 hour sessions, mind blown. Oh, there's a whole bunch. Everybody agrees with me that you're amazing.
Oh, thank you. So sweet.
So, anybody have a question out there that you want us to answer? And Kathy, I am so sorry that I accidentally unmuted myself and you heard me talking to somebody else.
No problem. I just wanted to make sure you knew that you did.
I'm not sure I understand.
Oh, and now my computer's talking to me.
All right. They're too smart these days, these computers.
Well, that's okay. I said something to Aaron earlier, and I might have said a not nice word, and my watch popped up and said, "That's not very nice." And Aaron goes, "Who just said that?"
Oh, that's funny. And this is our email address I'm putting on the screen now. If you think of a question later and you want to let us know that you were in this training and you want to send the question in or take advantage of that discovery consult offer to get on the phone with a certified specialist, please just email here and our staff will take care of that for you.
Okay, so some people have some questions about the joint.
The joint, okay.
And how is a chain like the joint able to see Medicare patients without billing Medicare, given that it's illegal to direct a patient to select option 2 of the ABN?
So someone who is not enrolled in Medicare, as the providers of the joint are not enrolled in Medicare, should not even be using an ABN. So if they are using an ABN, it's incorrect. What some people may not know is that the joint has actually hired us to help them with this. And we have been working with them. The simple answer is seeing a Medicare patient and not being enrolled, no matter who you are, is not appropriate. They are, as anyone is allowed to, making certain choices based on the other areas of risk within their practice. So if a Medicare patient comes in and you say to them, I'm so sorry, I'm not enrolled in Medicare and I can't treat you here, I'm happy to give you the name of 4 or 5 other doctors in the area that are enrolled in Medicare. And that patient says, oh, but I want to see you and I don't want Medicare billed. In fact, I'm going to instruct you not to bill Medicare. No matter who you are anywhere, there is a special form within your HIPAA program, assuming your HIPAA program is valid, viable, and accurate, that allows that patient to direct you in that fashion. Now, the joint may be moving in that direction. That's something that we have worked with them on in regard to HIPAA. But I can tell you that you should not automatically assume that just because someone does something, they're allowed to do it. And I know that in certain states, right or wrong, doctors have reported joint doctors to their boards. There have been a lot of blow-ups around the country. And yet, interestingly, I received an email from one of their compliance officers just this last week that said, we are growing so fast, we need doctors, and all of our recruiting services are unfortunately not able to find doctors. Do you know anybody looking? So there's something about that model that is appropriate. No judge's robes on about it whatsoever, or it would not be growing at the rate that it is. And while all of us wish every doctor would do everything appropriately and compliantly, they just don't. So I cannot give them a pass for the way they're handling it now. What I can give them is kudos for attempting to move in the direction of getting it fixed. So I don't know if that's the answer they were hoping for, but that's the only one I have.
Well, no, and I saw that it come up, and I was going to bring it up to you because you and I have talked about this before.
Yeah.
We talked about this before you started working with the joint, and we've talked about it since. So I really was looking forward to hearing you talk about this because, like I said, we've had conversations about this, and it really comes down to this: regardless of what the model is for that clinic, it's just doing the right thing, and they are making the attempt to do the right thing.
Hopefully moving in that right direction and dealing with the things that need to be done. And quite frankly, I'll go on the record happily that I think the ability for a chiropractor to not be able to make their own choices about their business, every chiropractor, and be limited as one of the only types of providers that has to enroll to see a Medicare patient is discriminatory. And I hope that the opt-out for doctors goes through Congress and gets changed in the law, because I think it's inappropriate, completely inappropriate. And I hate that it's there. But yet I also know that we must strive to follow the rules of the land.
True story. And unfortunately, these are the rules until that finally gets we have the ability to do that. So do you have to do all of the exams? And wait, hold on a second. That just people are typing and I keep losing my spot. Okay. I mean, bless you.
I was blowing some fuzz out of my keyboard.
Do you I just noticed how dusty mine was today. I don't know where all this dust comes from. Do you have to do all of the exams and forms for an Advantage plan as you do for Medicare?
All of the exams and what?
Do you have to do all of the same exams and forms for Advantage plan as you do for Medicare?
So Medicare doesn't require any forms at all except for an ABN. And as I said earlier, the Medicare Advantage plan may have their own ABN form. So every payer that you deal with, if you're in network, you'll deal with their rules. Examinations are not required by anyone. So to say that, oh, I have to do an exam every 30 days. That's not true. That's not the rule. There, you saw the documentation guidelines that I posted. That is required. And that would be a requirement probably under your Part C plan as well, because that's what establishes medical necessity, which is what makes the service payable.
Okay, so it says, when a patient has a new episode of care, must we bill for an exam each time?
Did you do an exam? If you did, then you have to bill for it. If you were able to evaluate that patient within the confines of your routine visit and get what you need, maybe you're only going to prescribe 3, 4, 5 visits, and you didn't have to do a fully involved, full-blown evaluation, then maybe you don't need it. But that's up to the doctor's discretion. In the same way, the doctor is held to the consequences of not having enough documentation if you didn't do it right. So doing it and not billing for it, not okay. doing a modified version within the confines of your CMT might be appropriate. We always do proactive chart reviews. If doctors want to have a certified specialist review their documentation and weigh in on it before maybe a bad guy does. And that would be a circumstance that we have people look at all the time and say, here are 2 episodes of care. There wasn't an evaluation at the beginning. Did I do enough? And we were able to help them understand what was or wasn't there.
And I have to just say that I strongly recommend, like, I can't say this enough. You need to have a third party audit at least a chart, if not 2 or 3 charts, to know, because it's hard to know if you're doing things the right way, the wrong way. You can have an idea, you can think you're right, but warm, fuzzy feelings will not help you in an audit situation. And it is better to get somebody like Kathy and her team to audit those charts for you first before you ever have to go through an audit situation. And I'm actually kind of blown away by how many people, when I talk to you about this, I'm like, well, have you ever had somebody audit your charts? We audit our charts. No, you can't audit your own charts.
You generally, any of us don't know what we don't know. And there are blind spots that we can't know, but somebody else can see that blind spot that we can't. And when you're talking about something as valuable as your license and your practice and your income, it's just silly to play with fire like that.
It is. It really is. I love that. You don't know what you don't know. And I'd rather know, even if what I thought I knew was right was wrong, but I'd rather just know for sure. Okay, I'm going to end with this last question because Kathy's got a tight schedule today. And luckily I can beg, plead, and bat my eyelashes, and she will do things for me like be on webinars.
Of course.
We've been billing some therapies to Medicare with GP, GY modifiers in the hopes that Medicare cross those over to supplementary policies. We haven't found that supplements typically pay for anything that Medicare doesn't already cover. What are your thoughts?
Well, that tells me that we have not verified that secondary to know whether or not they have coverage outside of Medicare's covered services. Again, I mentioned earlier, the biggest travesty we have is that we don't verify Medicare. It is critically important to verify every payer that a patient has. Go to that HETS website. Know whether it's a supplement, a Medigap, or a secondary. If it's a true secondary, it could behave like a group health plan, but you don't know until you verify. And it is a business procedure that offices have let go by the wayside and are paying for it, unfortunately, with this type of thing. Not that I would not want you to bill it. You billed it perfectly, by the way, with exactly the right modifiers. But where it went wrong is you probably didn't know that you should have collected that money at the time of service. Because that now you have to go chase them after it comes back as denied. So had you verified it appropriately up front, you could have set up a payment plan for the patient, given them an expectation of their financial responsibility, signed them up for ChiroHealthUSA to access those discounted fees for those services, and you would have been way ahead of the game. So verify and then take care of business up front. Don't wait and be reactive.
I miss you so much.
And you too, my love, my little Lisa Marie.
When I grow up, I'm going to be just like Kathy.
Oh, please. You're already there.
Nope, I'm not. But one day I'm going to be. I try really hard. Y'all just have no idea. Seriously, I'm her #1 fan.
Can you tell? You can certainly tell. I love you. And I'm so thankful to have been here. And hopefully this has been useful for your audience.
Absolutely, it's useful. I could do a Kathy show like all the time. I really could. But Kathy's busy. Kathy also, and also I don't know if you talked about Facebook because I've been in and out with some stuff, but if you're not following KMC University on Facebook, all I'm going to say is, what are you thinking? Because they post so many updates on there. They answer questions on there all the time, which I love. It's like one of my favorite things to see in my feed. I tell y'all all the time, we have a lot of speakers that come on here and they're like, oh, follow me on Facebook. And I always tell you who my favorites are. Follow KMC University on Facebook.
Thank you. And if you don't have a plan for the new E&M codes before January, I'll be happy to come back and share that with your folks too.
We'll be talking.
All right.
Okay, everybody, we got to wrap this up because Kathy is a busy woman with things to do, and I have kept you over 10 minutes over your time.
No
I
problem.
miss y'all too. I can't wait to see everybody in person. Yes, this was recorded. A link to the recording will be sent to you within the next hour. You can also access it on our website under archived webinars, or you can even do better and search for presenter and look up Kathy Mills Chang, and you can see anything and everything she's ever presented on our webinars for the last couple of years. So check it out. Please reach out to info@Kansas University for any additional questions that you may have after today's presentation, or you can forward it to me, and it just gives me a good excuse to talk to all my favorite people that work over at Kansas University. If you don't take care, schedule that discovery consultation at the $49 fee, you have lost your mind. So reach out to them because they are an amazing resource. Their website is phenomenal. Their Facebook, phenomenal. Did I mention they're pretty amazing? Okay, now y'all know what I'm talking about. I'm going to wrap it up and see y'all next week. Same time, same place. Bye.
Thank you.